Good afternoon, everyone. Welcome to today's Endocrine Grand Rounds, and we are very pleased to have Dr. Mike Tuttle come today all the way from New York uh, and give us, he's back here to his hometown or his, where he did his medical school training. Dr. Tuttle is currently the Chief of Endocrinology Service at Memorial Sloan Kettering Cancer Center and Professor of Medicine at Cornell Medical School. He did his undergraduate training at Northern Kentucky University, did his medical school here at the University of Louisville, went to the Eisenhower Army Medical Center for his residency and his fellowship at Army Medical Center in Seattle. Um, he went to Memorial Sloan Kettering in '99, and since then he has been there, and gradually becoming a full professor and now chief of the endocrine service at Memorial Sloan Kettering. Of course, I think all of us know him very well because of his uh, widely known work in the field of thyroid cancer. He has mentored numerous students. He has won awards like the Brave Women Award from the American Thyroid Association, has won teaching awards at Cornell and Memorial Sloan Kettering, has over 300 publications to his credit. Today, he's going to talk about risk stratification in differentiated thyroid cancer. So, Dr. Rahul, welcome.
Thank you very much. It's wonderful to be back in Kentucky. It's one of the few places I don't have to hide my accent, so I can talk the way I grew up. Grew up initially in Laurel County and then up in northern Kentucky, where I met my wife as a teenager. And so she's down here visiting family and friends as well. So a delight to come back. So what I thought I would do is I really hate giving an hour's lecture. I don't know an hour's worth of stuff. So what we'll do is we'll talk for about 20 minutes to show you the overview of the risk stratification. And then I brought 8 cases. These are the cases that I get emailed every week, every day on. Some of these the fellows have already asked about. And so we'll work through the cases and we'll see how many we get through. Some of the options for the questions will be do surgery, don't do surgery, do radioactive iodine. And then there's one called phone a friend. So the first years can ask the second years can ask the faculty. If they can find a surgeon, they can ask a surgeon, and then we'll see where it goes. And whatever you guys say, I'll repeat back into the microphone so for the folks that are online. So what I thought we would do today, no relevant disclosures, give you some idea about how thyroid cancer has changed since I graduated from here in '87 and started my fellowship in 1990. What's changed over time, how we've moved from one size fits all. This sort of practical framework of risk stratification that really guides everything that we do. So I'm going to show you that, and then we'll take the cases to sort of work through that and see where we go. Remember when treating thyroid cancer was easy? Some of you young guys don't remember that. The old people in the room, remember when it was easy? Everybody got a total thyroidectomy, everybody got radioactive iodine, and everybody did great. They did fine. They were fine. So we had to complicate that, right? And now you can't read through the guidelines. The guidelines are now, I don't know, hundreds of pages long at this point where you try to read them. And we've gone from this one size fits all to a very individualized risk stratified approach. But that's not just thyroid cancer, right? If your mom or sister had breast cancer, you wouldn't want one size fits all for mom or sister, right? Tell me about that breast cancer. What's the HER2 status? What's the triple net, right? What's right for my mom in this situation? And thyroid cancer has just been part of that discussion. And I think largely what drove that discussion is this graph. But this graph has showed that dramatic rise in thyroid cancer we saw in the early 2000s. I mean, we lived this. Every year we would watch the SEER data come out, and it wasn't a surprise, right? We were all feeling it in clinic. We were seeing all these thyroid cancers, but what were we seeing? Lots of low-risk thyroid cancer. Not necessarily all papillary microcarcinomas, but if you look at this curve, the vast majority is less than 2 centimeters. So that approach that I had learned from Dr. Mazzaferri and Berman and Wartofsky that worked for big tumors that presented with palpable lymph node metastasis. We barely had CT scans back then. We didn't have ultrasounds. And so the disease I was treating back then was a surgical disease and neck dissections and radioactive iodine. But now by the year 2000, 2004, think about the last 3 or 4 patients you saw with thyroid cancer. How was their thyroid cancer found? Probably not on physical exam. It was found on what? CT, ultrasound, done for some other reason. Or my favorite is the well-meaning primary care doctor that their note says there's a lump on the left-hand side and the ultrasound shows a lump on the right-hand side, right? I don't have the heart to tell them. They're so happy their doctor found it. I don't have the heart to tell them that they really didn't. So we just pretend like they did because I need the private guys to refer patients to me at Memorial. So what happened was over time, our clinics began to be flooded with all these low risk thyroid cancers. And it really didn't make sense anymore to be putting all of that aggressive therapy on these lower risk cases. And the first thing you see in the guidelines, 2006, 2009, began to roll back some of that radioactive iodine because we were doing 1 centimeter papillary cancers, 1.2. Risk of recurrence was 1 or 2%. Why would we give radioactive iodine? And then there was also some data about side effects of radioactive iodine, dry mouths and blocked tear ducts and a little increased risk in secondary malignancies. But I will tell you, you get a secondary malignancy, it'll rock your world. I've been doing this for a while, and I had a conversation last Tuesday with a young patient that I treated 10 years ago for metastatic struma ovarian, thyroid cancer that started in ovary, was metastatic. I gave her 2 doses of radioactive iodine, thought I was being very conservative. We put her into remission, and the conversation last week was she was just diagnosed with AML. I was being conservative, guys. Doesn't take me like that to sort of say, what am I doing in this low risk? At least she had distant metastasis, and I felt like I was probably doing the right thing. But those kind of observations in low risk makes you think about it. And so what we saw in the guidelines, by the time we wrote the 2015 guidelines and the NCCN guidelines, and if you look at all the up-to-date stuff that we write now, we were beginning to ask, if we're not going to give radioactive iodine, do we have to do a total thyroidectomy? When we were given radioactive iodine, it was easy, right? You had to have the whole thyroid out. But if I'm not going to give you radioactive iodine, now I got to justify being on the other side, putting the nerve at risk. Hypoparathyroidism, right? I mean, I can't stand hypoparathyroidism, and I'm not even the patient. I mean, that's a lifestyle changing, devastating problem for many patients. Began to ask, well, what are the outcomes after lobectomy? Well, how do people do? And then even questions like, is immediate surgery really necessary? If you find a 4 millimeter papillary cancer in my dad, who's 85-year-old farmer in Florida, you're really going to treat him? Or should you apologize that you made him a cancer patient because you stuck a needle into a 4 millimeter nodule and now my dad thinks he's a cancer patient? That's a good cancer. Don't worry, you're going to do fine. But how does dad represent that? I got cancer, right? Things like that we had to really sort of think about. Could we do active surveillance and then some thermal ablation? Now, this is what the paradigm looks like now. We start from the time the nodule's detected, not from when we do the surgery, but risk stratification starts all the way back here before you do the biopsy. Find the nodule, avoiding overdiagnosis, avoiding underdiagnosis. If you find a 4 millimeter anaplastic, please treat it, right? You never find one, but if you did find one, we'd want to treat that. If you find a small medullary, we probably want to treat that, right? So overdiagnosis and underdiagnosis, and it also goes through long-term follow-up. We've had some people seeing us every 6 months for 20 years that have been cured of their thyroid cancer. Several years ago, I made a Kaplan-Meier curve that showed overall survival. And what's your overall survival if you visit New York every 6 months for 20 years with papillary cancer versus if you never saw me again? Guess who lived longer? Yeah, the people that never saw me again. Because if you come to New York, there's a death rate of coming into the city from trains and buses and right. I mean, it's all about overall survival. And if you got people driving all the way up from Laurel County to see you, and their risk of dying is essentially zero, we may be hurting more people than we help them with a simple act of follow-up. Does that hurt our heads? Yeah, we have to sort of tell the lawyers about that, but I worry about things like that. And then the key is finding the balance. We're going to talk about this more tomorrow about sort of how we find this balance. So avoiding overtreatment, avoiding undertreatment. In thyroid, we can never get the pendulum in the middle. We're either giving everybody radioactive iodine and everybody surgery, or now people introduce me and say, he never does total thyroidectomy. He never gives radioactive iodine. No, we give it when it's appropriate, trying to find that middle balance. Jerry Doherty, who's a surgeon from up in Michigan, I heard him talk a couple years ago, and Jerry said his goal was to do just enough. His strategy for thyroid cancer was just enough to give him excellent outcomes. Now that's different because before we would do everything And then you had to earn not getting everything, right? The default was everything, and let's pick out the people that don't need that. Jerry flipped this on his head. Said, no, no, no. Most people are going to do fine with just enough. Let's do just enough in most people. Lobectomy, total, radio, whatever just enough is, and then reserve the extra for folks that need more. Now, in 1990, when I graduated, started my fellowship, risk stratification was really all about this initial risk stratification. It was about the path report. And this is in the days of Mazaferi. It's when everybody was getting radioactive iodine. And in fact, I didn't even really need the whole path report. If I had page 2 that showed there was a positive lymph node, I'm done. Radioactive iodine. That's all there is to it, right? So that was risk stratification back then. But the trouble was that whole risk stratification was predicting people that died of thyroid cancer. How many patients do we have dying of thyroid cancer? Not very many. How many people do we have with recurrence and persistent disease? The issue was the recurrence. And the other issue was these estimates didn't change over time. For many years, I showed a picture of my 3 kids when they were babies. And I said 2 of them were really good. And one of them, my wife and I wanted to sell when he was 16. Just, we would have gotten rid of that kid. Could you predict which one of the 3 it was? And I picked these angelic pictures. I'm not even sure they were my kids. But the point was, you couldn't tell from them what was going to happen years down the road, right? So we needed some system to predict risk of recurrence and to do some stratification before surgery. So now the way we think about this is as soon as we see a thyroid nodule, we begin to ask questions like, is an FNA really necessary? Could we harm somebody by making them a cancer patient? There's some psychiatry literature that shows in patients that had thyroid cancer, before they had thyroid cancer, if you ask them to tell their life story, it's before I got married and after I got married, before I went to school, after I went to school, before I had my first publication, after my last publication. Guess what happens when they have cancer? How do they tell their story? Before I had cancer, after I had cancer. If we're going to diagnose cancer and make people cancer patients, we better have a good reason to do that. Is immediate surgery necessary? Now, everybody always says yes, but even in the early days, I showed a case of a 29-year-old patient of mine had a 2 centimeter, 2.5 centimeter papillary cancer that clearly needed surgery, but she wanted to wait 3 months so she'd get married. And I said, fine, right? We're fine with 3 months. It's Manhattan. So her parents then sent them to Europe for a 3-month honeymoon. And she wanted to know if she could wait for 3 months. And I said, sure. So now I've observed for 6 months. She came back, had a new job at JP Morgan Chase, wanted to wait another 3 or 4 months. And I said, well, it hadn't changed in this entire time. And now I'm starting to get nervous, right? Because I've been watching for a year. And she eventually had surgery a few years later. But did I do her any harm? No. We watched her for a while. Total thyroidectomy or lobectomy. So the real question in this early piece, when you find the nodule, is this a good candidate for minimalistic management? That's what I'm asking. Would you be good for either no biopsy and watching, do a biopsy, do a lobectomy, do just total thyroidectomy? What's just enough for that patient? And we had developed some words to sort of say, how do we describe this risk stratification? Because low and intermediate and high and stage 1, that didn't really sort of fit for this arena, right? And so we came up with 3 words that said ideal, appropriate, and inappropriate. You're an ideal candidate for minimalistic management, right? So you're probably going to do it. Nah, you're an inappropriate. That's the just enough, right? You need a little bit more. And we realized what we were looking at with about the first 50 patients we started watching. JP Brito was my fellow who's now a thyroid guy at the Mayo Clinic. And JP and I, in the first 50 patients that we saw, I'd gone to Japan a couple years before, and the Japanese had been doing observation for about 10 years at that point. Professor Akira Miyauchi, you guys probably know, Ito, who you probably know. Highly recommend go to visit them. Kuma Hospital, they'll take you to dinner. It's in Kobe, Japan. You should go do a fellowship there. Just take a few months. It's good. They'll treat you great. And they helped us sort of understand. And what I realized is when we were deciding, are you a good candidate to watch? This is in that early active surveillance days, we were looking at sort of 3 domains. What was the tumor? How big was it? What was the location? Is it near the nerve? Is there lymph node metastasis, right? Everything about the tumor. Then there was also about the medical team. I'm spoiled. I got 20 radiologists that do nothing but thyroids. That's what they do all day long. Each of them do 20 or 30 thyroids a day. We have different ultrasound people for breast, different ultrasound people for the left elbow, the right elbow. We're subspecialized. So I've got this wonderful team. I've got a great bunch of surgeons that can follow these. So I have a wonderful team to be able to do it. And then there was this whole concept of the patient characteristics. What were the patient's opinion? And I'll show you in the lecture tomorrow, I'll start with the case, and it'll be about a 4 millimeter papillary cancer in you. And half of the room will say, nice chat, get this out of my neck. Just, I want it gone. Nice chat. Thanks for driving all the way, flying all the way to Louisville. Get this out of my neck. And the other half will go, maybe I can watch that for a little while. My best example is one of our nurses. One of our nurse practitioners. She found out she had a thyroid nodule on a Wednesday. On Thursday, she managed to get herself a fine needle aspiration biopsy with a rush. So by Thursday night, she knew she had papillary thyroid cancer. On Friday morning, Ashok Shah, my surgeon, and I see a clinic together on Friday morning. She showed up to clinic on Friday morning in PO just in case Ashok could do the surgery. Do you think she was interested in active surveillance? She pointed out to me she'd already been watching for 18 hours, and that was about as long as she was going to watch. Absolute true story. So we did her surgery, not that same day, but she had. Now, the other question is, if we're going to do minimalistic, what about lobectomy versus total? So we can start with the same way. What's the tumor? What's the medical team? Now, the medical team, I think, is interesting because often people will say, well, if you've got a really good medical team, then you can probably do lobectomy. How about if you have a really bad medical team? How about if your surgeon does one thyroid surgery a year? Most people that have thyroid surgeries in the United States are operated on by a surgeon that does one or two a year. We don't all live in ivory towers. That's the reality. If you had a surgeon that didn't do very many, maybe you'd lean toward lobectomy as opposed to hypoparathyroidism, right? So that medical characteristic doesn't mean you only get special things if you're at the big locations. I've been in other countries, they have no access to levothyroxine. I can't do a total thyroidectomy. Can't recommend that. And leave somebody with no thyroid hormone the next 20 years, right? I don't care how much I want to do that. Understanding that medical team characteristics. And then the other thing that when people choose lobectomy that they have to understand is there's 2 additional data points I need before I know that you're ideal for lobectomy. One of those is in the operating room. We routinely tell patients the consent at Memorial is lobectomy or total thyroidectomy, and let the surgeon make that decision in the operating room. That's why we don't have a lot of completion thyroidectomies, because that decision is made on those intraoperative findings. And then I won't really know till about a week after surgery when I get the path report. And if you show some patients this, they go, nope, put me to sleep. One time, doc, that's it. I'm not going through this 2 times. Other people go, no, I'll take that little bit of unknown. They'll make me guess. What do you think the percent is that I'll have this or that? When I started, it happens all the time. And when I started working from home during the pandemic, I was in, like all of us, went to our formal dining room after 2 months, my wife announced this was no longer temporary and I should get my butt upstairs to one of the bedrooms. But before that, she walked past me and she said, I hear you talk to the patients all the time. Did it ever dawn on you that you might not be right? Because when people ask you what the percentage is, you give them some number. And I hesitated for a second and she said, oh my God, it never dawned on you. You might not be right. Now, the second part is what about the initial risk stratification? This is where we all know we're used to this. I like the AGC, the stage 1, 2, 3, 4. To be honest with you, I didn't like edition 1 through 7. It didn't help me. The 8th edition, probably because I did a large part of it, I like. But we're able to separate out survival, disease-specific survival a little bit more in the 8th edition. So using that to predict whether they're going to die, and using the ATA risk stratification system of low, intermediate, and high to do risk of recurrence. I tell patients this is how you're born. We're waiting our 7th grandchild that is due any day. And my wife says if that baby's born while we're down here, I'm dead. So my daughter-in-law promised me she was going to keep the baby until Thursday night. Otherwise, if you see a murder tonight in a hotel, it's probably me. But this is how you were born. This is your height and weight. This never changes. That's the pre-test probability where you started. So my fellows will always say, you saw this patient 25 years ago, she was 29 years old at the time, stage 1, low risk. I've got a picture in my head. I know who that patient is. This is a 65-year-old, stage 4, ATA high risk. I've got a picture in my head about how those are. Now, one of the things that a lot of people don't understand is this initial post-op risk stratification. When we put the AJCC 8th edition out, we specifically wrote in there, you can use all the data for 4 months after surgery. Think about how much data you have 4 months after surgery. You've got a thyroid globulin at 6 weeks to tell you if you're missing anything. If you're doing radioactive iodine, you've got the radioactive iodine scan. If you think the surgeon missed something, you've got an ultrasound, you've got a CT scan. So part of the reason that these risk stratifications work well, it doesn't stop 1 minute after the operation. Everything that first 4 months, you should wind in and tell the patients you're really not going to know their ATA risk or their sort of AJC stage until we get through that 4-month point, right? And that gives you a lot of good information. Now, the other thing that would happen, as we found out, is that things can change over time. So I tell patients, we'll start with that ATA risk, that disease recurrence. We'll start with your first post-op thyroid globulin of 6, and then we're going to plan sort of the next 2 years. It's hard for me to see beyond the 2-year time horizon. So the next 2 years, based on your stage and your risk, this is how we're going to do the follow-up. This is what I expect. I live about an hour out in the countryside outside of Manhattan, and every day I drive down into Manhattan and I use Waze. Do you guys use Waze, the thing? And there's like 2 big bridges I got to go over. And so when I leave my driveway, it'll say, here's how you're going to go. And then 30 minutes later, what's it say? Better go that way. Yep. Or that's what we should do in clinic as well. This is where we start, but based on the thyroid globulins, based on the ultrasound, we're going to sort of begin to say, look, we'll start with this plan. And then as everything comes out, we will reevaluate and readjust the plan. And patients are fine with this. They are totally fine with it. Here's what we're going to do, because they think about it this way. My daughter took me some pictures. For the surgeons, you probably know Michael Ye. Michael Ye is a surgeon from out in Los Angeles. And when we were talking about this concept of dynamic risk stratification, Michael said, I love the concept. We were driving in a taxi back to an airport from lecturing somewhere, and Michael said, I tell my patients, the first time I see you, the picture is a little bit fuzzy. And every time I see it, it gets a little bit more clear. And I love that so much. I called my daughter before we got on the plane. I said, take me a picture of that flower in your front yard. And then I called Michael and I said, would you mind if I call this the focus of yay? Because that sounds like an ancient Chinese proverb. It's just got to be right. And so Michael said, yes, so it's the focus of yay. So we needed some way to describe what were the follow-up status, right? Because we're not changing ATA, we're not changing your risk, but I need to be able to explain what's your status when you come back at 6 weeks, 6 months, 1 year, 2 years, 5 years. And so we came up with these 4 terms. Excellent response is the oncologic version of remission. If you want to use remission, it's okay. It's not banned in thyroid cancer. That's what excellent response is. You're in remission, no disease that we have. Biochemical incomplete response, that's those thyroid globulin values. Remember when we used to be able to cure people? Because now our thyroid globulin assay reads all the way down to 0.1. Apparently, I can't cure anybody anymore. Everybody has a thyroid globulin of 0.1. And when it's 0.2, the next time I have a 30-minute discussion about why their number has doubled, right? So I used to say, I want the best ultrasound on the planet. I want the most highly sensitive thyroid globulin. And if you promise not to tell anybody, now I wish I had that ultrasound from the 70s where you could see golf balls and not much else. And remember when the thyroid globulin, you couldn't read less than 1? It was awesome. I thought everybody was cured. Everybody was fine. We'd talk about their kids, my kids, their grandkids. That minimal disease detection has led to some problems for us, right? So that's where we would look. And if you look at these outcomes, now this has been replicated now in about 30 different centers all over the world, ivory towers, non-ivory towers, community hospital. This is the natural history of this disease, that if you have an excellent response, the recurrence rates are 1 or 2%. You're going to do great. There's almost no deaths in there. And in fact, if you keep doing ultrasounds, all you're going to find is false positives. In our false positive on the ultrasounds 35%. And so if you have an excellent response and I keep doing ultrasounds, I'm using a test that's 35 times more likely to find false positives in real disease. That's a problem, right? We got to get out of that ultrasound business. Biochemical incomplete, most of these will spontaneously resolve. These TGs go down over time. You can take the credit for watching them go down. The few that develop structural diseases, like the case we presented today to me, the thyroid globulin going up every time. That's the signal to go look at it. The structurally incomplete, that's where we have to focus our work. That's where the deaths are. Not structurally incompletes in the neck, but distant mets in the lungs. Those, if you're going to worry about people dying, that's the group. It's the structurally incomplete. And then we had the indeterminate group. Indeterminate, because I did the first 500 cases myself to figure this out on the chart review, I just couldn't classify them. They weren't totally normal, but they weren't cancer. But I didn't want to call them excellent, but I didn't want to call them disease. And the original term I used for this was acceptable. If you look at the early papers, I called this acceptable. When they put this in the ATA guidelines, they told me that acceptable was too judgmental because it implied you didn't have to do anything. And I said, I know, that's why I chose the word acceptable on purpose, because I thought if you had to tell somebody it was acceptable, it would be hard for you to do something. It was judgmental. But like all of us, we want our stuff in the guidelines, so I agreed to let them change it to indeterminate. So that's where that indeterminate terminology comes from. Now, one of the things that came up, and we talked about this with the fellows, is all of this structural incomplete disease. Because you got to remember, we used to treat stuff with our hands. And in the 90s, when we were treating thyroid cancer with our hands, our survival rate was still 99%. We didn't change that with the ultrasound. We didn't change that with thyroid globulin. We did a lot more treatments, but we didn't make any real difference in overall mortality at all. And what that means is we have to tell people we're going to detect things that we don't want to do anything about. And so a few years ago, we came up with this language about detectable findings versus actionable findings. If you operate on a 25-year-old guy that has 35 positive lymph nodes in the neck, you better tell him we're going to find detectable findings. We're going to find some little funny lymph nodes and everybody's going to worry about them. We're going to have some low-level thyroid globulin. But just because we find something doesn't mean we're necessarily going to do anything about it. So differentiating what we call detectable, actionable, non-actionable, and you can tell my bias. My bias is that the bulk of stuff that we find, we don't need to be treating. We'll hurt patients more than we help by going back with repeat neck dissections. We try to make that last molecule of thyroglobulin go away with the 35th dose of radioactive iodine. We're going to hurt more people than we help because thyroid cancer is often quiescent. Now, that doesn't mean you can ignore them. The, non-actionable doesn't mean you ignore. And so you have to say, well, what are the things that would make me change from detectable to actionable? So this is our pilot's checklist. These are the 5 things that I think about. Whether I'm seeing a small lymph node in the neck that I think is structurally incomplete. Now you'll notice when we put detectable, we didn't say detectable disease or detectable cancer. We called it detectable findings. So you're not obligated to biopsy, you're not obligated to do anything. It's a detectable finding on an ultrasound or a CT or a blood test. And if we're in the structural disease, we're going to look what's the size of the nodule or the metastasis. We're going to look at how rapidly it's growing. Bigger, rapidly growing, we're going to need to do something, right? We don't want to let it hurt somebody. What's the location? Sometimes small things are in bad locations, near the recurrent laryngeal nerve or small lymph nodes in the neck or near the bronchus, where if they grew, they would cause us a problem, right? So location counts. Symptoms, or if it's likely to develop symptoms. And then the last is patient preference. There are some people that as soon as you detect it, they want you to treat it. They could not stand watching whatsoever. And then there are the people that go, well, okay, if I don't have to treat this now, what's the harm if I watch? Am I making the surgery harder? Is it going to metastasize? Is it going to spread? They're open to sort of thinking about that. And so understanding that our tools are so good and our minimal disease detection is so good that we're going to be faced with situations where we're going to find primary disease that we think doesn't need to be treated. We're going to find recurrent disease that doesn't need to be treated right now. And the real reasons are I can't cure you if I treat it. I may hurt you more than I help you. I don't think it's going to change. And as long as the patient is willing to watch with me, I've never gotten in trouble watching somebody. I've gotten in trouble doing surgery too soon. I've gotten in trouble giving too much radioactive iodine. But this concept that this dynamic risk stratification, I tell the patients, I'm not saying we're never going to do surgery. We just don't need it right now. Let's look at it again in 6 months. Come back and see me in 6 months, do the ultrasound. And then after a while, come back and see me in a year. This has been stable for a long time. And just keep an eye on it with me. And when it changes, we'll have a discussion about whether or not we need to change it. So the basic construct is when you're seeing anybody with thyroid cancer, from either day one when you walk in the door, from the time they find the thyroid nodule, we start to think about risk stratification. And in that early part, it's, are you a candidate for minimalistic management? That could be active surveillance, that could be lobectomy, that could be total with no radioactive iodine. And then we'll say if you need to be treated, we'll see where you are on the ATA risk and risk of recurrence. That helps me risk stratify where you're born, plan that initial year. And then every year that they come back, every 6 months they come back, even 6 weeks after surgery, that first thyroglobulin at 6 months, 6 weeks tells you a lot about that patient, right? That's an early response to therapy. Or calcitonin drops from 8,000 to 0 in 3 weeks. That's a great response to therapy. And we'll change the plans over time. And remembering we're going to differentiate detectable from actionable. And then my bias is strive to do just enough. Okay, you with me? So you don't have to memorize any of that. Ali Al-Azrani is the chief of endocrine at King Faisal Hospital in Saudi Arabia. Did a sabbatical with me for about 6 months. And while he was over, Ali and I talked through all of this, and that ended up being that review paper in JCNM. So this is where we start, okay? So if you're in clinic with us, everything from the surgical decision-making to when we biopsy to when we do follow-up is going to be based on that. So let's see how many cases we can get through. We've done good. Yay, team. So here's our first case. All right, and I got the fellows here. So they made the mistake of letting me meet with the fellows first. That's what. So remember, you can phone a friend, you can phone a surgeon, you can ask anybody you want to. So this is a 54-year-old gentleman, definitely a young patient, right? Say yes. Yeah, we're good. But when we wrote the ATA guidelines the last time, the 8th edition, we made it 55, right? And it dawned on me after we wrote it and before it was published, I changed to 56. If I'd have thought about that, I would have made it 56 so that at least when it came out, I wouldn't have been in the old group, but now I'm definitely in the old group. This old guy gets a carotid ultrasound, finds a nodule. He's got a 5 millimeter thyroid nodule, and as often happens outside of the fancy ivory tower, in New York, the primary care doctors send people straight to radiology or pathology. Do not pass the endocrinologist, do not see the surgeon. There are freestanding clinics that do 30 or 40 fine needle aspiration thyroids a day. These guys are making a fortune. I'm really jealous. They really fed my papillary microcarcinoma observation program. So here's your vote. 54-year-old guy comes to see you. Active surveillance, lobectomy, total, and prophylactic central neck or ablation. So how many people say active surveillance? Quick, I got 8 cases. All right, cool. Liar, pants on fire. How many people say lobectomy? There you go, one honest person in the crowd. Total thyroidectomy? Not so much anymore, right? So when we begin to think about this, most people will say yes. In the United States, still 50% of these patients are getting a total thyroidectomy, not just lobectomy. 50% are still getting a total thyroidectomy. Now, the space that we're playing, this is that minimalistic space, right? We found the nodule. In fact, I would have said you should have done risk stratification before you stuck a needle in this. Now, the guys in Japan, Professor Miyoshi feels really strongly you should biopsy these because he doesn't feel like the patients will come back for their visits unless they know they have thyroid cancer. That's his logic, and it improves his follow-up. I've got some patients I'm following without biopsy. Most of them come to me with biopsy. But by the ATA guidelines, less than a centimeter, you don't have to biopsy. And in fact, active surveillance, you can watch without a biopsy. Because active surveillance says you're watching a nodule that's either suspicious or definite for thyroid cancer. So you don't have to do a biopsy. And so what are we going to think about in this guy's case? Well, if he's seeing me, it's easy. I've got 700 patients with papillary microcarcinoma that we're following. We've got the medical team to be able to do it. And it really revolves around his patient characteristics, right? We've all seen patients like this that say, nice chat, let's go to surgery, right? Surgeons often say, well, I've never seen anybody that doesn't want surgery. And I say, yeah, you have. It's the patients that say, can you just cut out my cancer? I don't want a total. I don't want a lobectomy, right? You've had this, right? Just cut out my cancer. It's the patient that cancels their surgery every time a week before, and you're on your 3rd scheduled surgery, right? My favorite was a patient that flew in to see me from Denver. I asked her why she came to see me, and she said, because I've seen every surgeon and endocrinologist in Denver. And I said, well, good. I'm glad to know I'm at the last of the list of that. And she said, no, all I wanted each one of them to do was get me an ultrasound. This was 15 years ago. And she said, nobody would follow me. So she just went from different doctor to different doctor. All she wanted was the ultrasound, and she read it herself. And so she was thrilled that I would actually follow and watch with her. And then one of my patients that lived in New Jersey was actually flying to Japan once a year to do follow-up because nobody would watch her 7 millimeter nodule. So, people do patient characteristics. So I often tell these patients there's 2 right answers. I find in cancer, people struggle between right and wrong. You don't want to be wrong in cancer, right? If you're wrong in cancer, that's a big deal. And oftentimes when people, they're given the option, you could do surgery or you could do observation, you kind of pick. And so years ago, I started framing this as there's 2 right answers. You can't be wrong here. I used to tell people, no matter what you choose, you'll be at my retirement party. But apparently that's not so reassuring anymore. It was when I was 30, not so much now that I'm 60. So I tell them you'll be at my fellows' retirement party as they do it. The other thing that's coming is thermal ablation, radiofrequency ablation, laser ablation, destroying these little small thyroid cancers. People that want to watch also don't want ablation. They're not worried about it. They just want to be left alone. But people that want a treatment that don't want a lobectomy, this thermal ablation for some of these is probably going to be the way to go. It's not FDA approved yet. We're doing it for benign nodules and that sort of stuff. But I think the future is for some of these people that just don't want to watch and want to be treated, having a thermal ablation with RFA or laser is going to be good. Now, what about this one? She's a 23-year-old. This is a real case. She really was a professional model. And the gig that she got was a radiology convention. And her job was to look really pretty and let people do ultrasounds on her neck. And they found a 1.3 centimeter nodule, no other abnormalities. She had a papillary thyroid cancer. And before they found that, she was planning on getting pregnant this year, married a couple years ago. Okay, so now it's a little bigger. So we're 1.3 centimeters instead of 0.5, right? I took it up a little bit. Now she's younger. She's 23. And now she wants to get pregnant. So how many people say active surveillance? Are the brave ones? I assume you guys have really good lawyers if you're saying, yes, that's good. Okay, I like that. We do too. It's good. How many say lobectomy? Cool. Perfect. Total thyroidectomy? Probably not lobectomy, right? So what were the factors that clicked you over into that situation? Well, you were thinking about the tumor factors, right? This is a little bigger nodule, but I'll tell you that we follow these up to about 1.5 centimeters. Apparently cancers don't understand the metric system. They don't know at 1 centimeter they're bad and 1.5 they're worse. It's a continuum. The real truth is when they get bigger than 1.5 centimeters, they're kind of filling the lobe. They're touching the front of the capsule, the back of the capsule, the trachea. They're hard to find one bigger than 1.5 centimeters. In young people, if you look at all the data, in old folks my age, only about 5% of these thyroid cancers grow when we watch. In young people, it's more like 10 or 20%. So she's got a little more risk of being able to watch. It's also to get your head wrapped around watching a 20-year-old for 70 years, right? I mean, that's kind of hard to get around. And what about pregnancy? Is pregnancy going to do anything? Maybe a little, right? There's some data that pregnancy could be a minor stimulus. I've had 10 or 15 of these ladies get pregnant and nothing happened. One of them grew, but she was growing before she got pregnant. She'd been following me for 4 or 5 years. She got pregnant, and after pregnancy, the nodule was bigger, but it was exactly bigger that we would have predicted. She was on the same growth. So some of the people that are told that their thyroid cancer changes during pregnancy, it was the natural history of the disease. But I have seen a few that dramatically changed during pregnancy. So she had to understand with me, if you decide to watch with me, I could do it because we could do it up to about 1.5 centimeters. But you're younger, it's a little bit more likely that it's going to change. Pregnancy might make a little bit of a difference there. And so then that becomes the patient characteristics. Oncologically, I'm fine. I would watch this, and I have lots of folks do. The people that choose to watch this, they've had a really bad experience with surgery. Their families had a bad experience with surgery. They want to treat themselves. I used to call my observation group observation. I don't anymore. I call them my self-therapy group. They've just rejected our treatments. They haven't rejected treatments. They do every herb I've never heard of. They do every healthy thing. They do something called exercise that I'm unaware of. They change everything. And I learned this because in the first 50 patients, I would walk in the room and I'd say, hey, good news, the thyroid cancer didn't change. And about half of them would be sad. What do you mean? Why are you not sad? And then they finally got brave enough to tell me they were trying to make this shrink. They were treating this. And so while stable was successful for me, it wasn't for them, right? They've been working for 6 months to make this thing. So I now no longer say good news. I walk in, I do the visit backwards because nobody listens to me till I talk about the ultrasound. I walk in, I say, hi, stable. And then they look at me and I go, any questions? Come back and see me in 6 months. And then we talk about the results. So that's how clinic really works. So that's where we went. What about this one? 47-year-old notices an asymptomatic nodule while shaving. This is a guy. When we notice a nodule while shaving, we generally watch it for 2 or 3 years and assume it's going to go away. That's what men do. Finally, his wife noticed it. Ultrasound 2.5 centimeter in the right lobe, highly suspicious. It's touching the anterior and lateral capsule. No other nodules, no abnormal lymph nodes. Biopsy was papillary cancer. And he sucks at shared decision making. He is not interested in shared decision making. Shared decision making is great because we can dictate that. And then when we get sued, we go, we talked about it. This is the old days. This is like, no, I don't have any preference. Just get me cured. And I'll leave the decision of surgery up to you. So 47-year-old guy, 2.5 centimeter nodule. He's been trying to ignore for 3 years. And ultrasound looks fine. Active surveillance, keep watching. Probably not. Lobectomy, good. Total thyroidectomy, perfect. Probably not ablation. We're getting sort of too big for ablation. So we're in this initial therapy space here. And this is what we have to talk to him about, right? We know about his nodule right now. Well, tell me about the medical team, because I know who's going to do your surgery. And my team, we know what our recurrence, we know what our parathyroid rates are, not the published stuff. We know what it really is. What's the real temporary hypoparathyroidism rate, which is 25%? What's the real permanent? It's 3 or 4%. So I know what all the papers say, but not real. Recurrent laryngeal nerve damage, temporary 3 or 4%, permanent 1%. So in our hands, we know what those are. And we feel very comfortable that we can do this safely. We know what the patient characteristics are. He's kind of not been too anxious for surgery this entire time. Now, he kind of gets a vote, but who also gets a vote in that room? His wife. Yeah. I've been married 41 years. I know better than take my wife to the doctors with it. I'm a minimalist, dude. I don't want to do anything. My wife is a maximalist. She made me go get another colonoscopy for God's sake, and it was just easier to do than have to like listen. It just kills me after 42 years. It's different, right? You've had this discussion in the room. You feel the discussion coming to an end. You go, yeah, in my heart of hearts, I think we're going toward a lobectomy, and the patient, whether it's a male or female, says lobectomy. The spouse or their mom or their dad or their primary care doctor the next day, or Dr. Google said you have to have all of this, right? All of that goes into sort of the patient characteristics. In his particular case, they both decided they were cool. They just wanted a lobectomy. They really weren't interested in the surgery, and he did fine with that. How about this one? 52-year-old female, total thyroidectomy. No neck dissection. We don't routinely recommend prophylactic neck dissections. We never have. In 2006, when that all got started, if there's one word in the guidelines I wish I would have never written, it was a sentence that I wrote, consider central neck dissection. In my head, consider meant think about it and don't do it. But apparently in the English language, consider meant do it. I swear to God, that's the way it was read. And based on that one freaking sentence in the 2006 guideline, and we worked so hard to get those sentences right, people read that as we should be doing prophylactic neck dissection. It was in the era of minimal detection, and back then we didn't understand it wasn't necessary. And so it took us down, 10 years of prophylactic central neck dissection off one sentence that said consider, because at Memorial, we would often consider, Shaha, my surgeon, describes it as a central neck inspection. He takes a look at it, and if there's no gross disease, we don't do anything about it in there. So that got us down that pathway. 2.5 centimeter papillary. Here's the path report. So we're now 6 weeks after, few weeks after surgery, minor extrathyroid extension, 2 little small lymph nodes came out, no other worrisome features. Shaha did this surgery. He did not think there was any gross extrathyroid extension whatsoever. So this is entirely microscopic. He had no idea there were lymph nodes. I don't really understand thyroid surgery, but apparently it's like your Thanksgiving turkey. There's a little bit of fat and gristle that comes out when they take the thyroid out. And pathologists now look through all that. And so we have to tell people you're going to find little small lymph node metastasis. So that's what we got in him. Now, 6 weeks after surgery, his thyroid got into 0.2. That's already a response to therapy, right? We're probably not missing distant mets. We're probably not missing big volume lymph node metastasis because this is a papillary cancer with no antibodies. TG should be a good measurement. Same thing if this was a medullary and the calcitonin was 0, right? You could have microscopic disease, but I don't think we're missing a bunch of big stuff. So that response to therapy, even though when we wrote this, I was thinking it took me 2 years. If you look at the early stuff in 2010, I said take 2 years to figure out response to therapy. And it was Doug Ross, one of the great endocrinologists at Harvard. Doug said, Mike, get rid of that time thing. You don't need time. If you have this response at 6 months, that's the answer. Just accept it and run with it. And he was right. So now in this case, so you got those minor features. He's had a total, so there's no discussion about going back to lobectomy. The question is, what are you going to do? You're just going to watch without TSH suppression. So he's got a TSH now of like 2. Just give him a 2. Not 0, but not 5. Put him on TSH suppression, bring the TSH down low. Do a radioactive iodine scan, just see what you got. Give a small dose radioactive iodine, 30 or 100. How many people say observe without TSH, just watching? Right? How many people? Okay. How many people say use some TSH to thyroid hormone to bring the TSH down a little bit? Okay, cool. How many people say do a radioactive iodine scan? Pretty unlikely to help us with the TG this low, right? 30 millicuries? Any 30 millicurie fans? Clearly nobody from nuclear medicine here. 100 millicuries? Probably not. So, I mean, these are all very rational, reasonable things to do because we're now in the initial risk stratification. We've got some early response to therapy with the thyroid globulin, and we're going through this same sort of pattern here. So in our hands for this patient, we would not give him radioactive iodine. Now, when you start doing a lot of lobectomies, what you quickly learn is there's some really important things to tell people about lobectomies. And it's the microscopic stuff you're going to find that you're not going to worry about. So in our discussion with somebody that's going to choose a lobectomy, we say, look, we're not going to be surprised if it's multifocal. I don't use that term, but you know what I mean. If we think we're taking out a 1 centimeter, we're not going to be surprised if there's some little multifocal because 30% of the time it's multifocal. We're not going to be surprised if there's some minor extrathyroid extension if it's sitting on the capsule. Doesn't matter if it's not gross. In AJCC, we don't care about microscopic extrathyroid extension, but we might see that. We might see some lymph nodes, we might see some microscopic extrathyroid extension, and we might see some multifocality. And we set that as an expectation, and I often use those words, we won't be surprised if we see that, and I will probably tell you to do nothing about it. And when they come back to see me a couple weeks after surgery, they often say, we read the path report, this is what you were talking about, right? Was this that little stuff that you were talking about that we're going to be okay with? So setting that expectation. If you don't, you get in the uncomfortable position that goes 6 weeks after, or a few weeks after surgery, you're looking at the path report and you go, yeah, we kind of knew that. Yeah, we knew it might be multifocal. Yeah, don't worry. We knew it might be microscopic. And about the third time you say, don't worry, and we knew it, they begin to say, well, you know, how good of informed consent did I get? Because if I knew there could be some microscopic limits, I might have chose total. If I knew there could be microscopic, remember that's our path, our third path. That if I knew that, what would have happened? Okay. So in our hands, we don't give these guys completion thyroidectomy. We don't do radioactive iodine. In San Francisco, they do. And so if you look at the rate of completion thyroidectomy after if this guy had a lobectomy, it's nearly 25% at UCSF because they believe in giving all these guys radioactive iodine. At Memorial, it's 5%. So, and again, the medical team characteristics, right? Where you're working and where your environment is and what your disease management team is going to do would inform your decision about how much or less radioactive iodine you're going to use in completion thyroidectomies. In this patient, we actually wouldn't even suppress their TSH. I know this one's technically intermediate risk. In our hands, this is a low risk patient. We're not worried about this patient. I think the key in this patient is avoiding excess stimulation. I don't want the TSHs to be 4 or 5 or 6, but I doubt that suppression does anything. I know suppression can cause harm, osteoporosis, AFib. I know we stink at trying to get the TSH where we want it. At least a third of the time we're trying to get the TSH at 1 and it comes back 0, right? So in this particular patient, I would have given them the option of not using thyroid hormone pills at all, which is what I'd recommend, especially with the thyroid globulin that's already nice and low. If you got a thyroid globulin that's more like 1 or 2, sometimes using thyroid hormone to suppress that and make that easier to follow over the course of the next year is logical. But in this particular case, we'd say you're doing fine, come back and see me in 6 months with some blood tests. We'll do an ultrasound once a year and change our mind in the future if we need to. What about this one? So there's 2 different questions on this one. So we're into the follow-up space now. So 33-year-old female, 2 years ago, so we're 2 years down the road. She had a total thyroidectomy and radioactive iodine, small papillary cancer, a couple of small lymph nodes. Now has an excellent response to therapy. She's in remission. Thyroid globulin's undetectable. Neck ultrasound's entirely fine. TSH is 1.9 because that's where we happen to be. And so the first question is, what are you going to do with a thyroid hormone dose? Increase, continue, or decrease? How many say increase the levothyroxine dose? Push a little bit more. How many stay right there where it is? Perfect. And how many say decrease? Because I don't know why anybody would say that. And what about this? How are we going to do the follow-up? So we're 2 years down the road. I'll tell you my usual follow-up in a patient like this is they see me about every 6 or 7 months for the first 2 years. 6 or 7 months, physical exam, blood tests, sometimes telemedicine these days. 1 year an ultrasound that I call my I told you so ultrasound. There's nothing there. Everything feels good. And then a couple more blood tests at 6 months. Then, and at the 2-year point, we draw a line in the sand. So it's pretty much every 6 or 7 months for almost everybody for that first 2 years, unless they just don't want to. So now we're to the 2-year point, and here's your options. She's an excellent response. Come back in a year with just labs and a physical exam. Come back in a year with labs and an ultrasound. And come back in a year with labs, ultrasound, and next CT. How many say just back with labs and a physical exam? Perfect. How many say back with labs and a neck ultrasound? How many are going to promise me you're going to stop doing that? No? Oh my God, come on, I'm back home. You got to throw me a bone here. It's like, so, okay, so here's what would happen. If you decided to give me a pregnancy test and the pregnancy test came back positive, how would you interpret that? Yeah, either there's a lot about me you don't know, or number two, it's a false positive. It's a great test if you use it to the right people. I'm firmly believing with the ultrasound, we're hurting more people than we're helping. Now, if you want to talk me into an ultrasound in 3 years or in 5 years, not never. People always say, well, you don't know what'll happen if you don't have an ultrasound. And I say, yeah, I do. It was called 1960, 1970, 1980, 1990. Memorial didn't start using ultrasounds till 2005. And our overall survivals were exactly the same. We did fewer surgeries, taking out little stuff. So as a group, I know you have to keep doing it. And I'm hoping that the guidelines, when they come out this time, are going to give you a break on that and say, use it less, because we're just going to have to stop doing that, which is where we are. Okay, let's see where we got, maybe one or two more. So this one's a 22-year-old. So 2 years ago, she had a total thyroidectomy, central and lateral. So she had bulky lymph node metastasis. So we're not surprised that she did not go into remission. We gave her radioactive iodine, pretty big papillary, lots of lymph nodes, big lymph node metastasis. You know, this is not, only about 30% of these guys get an excellent response when they present this way. The other ones are biochemical or indeterminate or structurally incomplete. So sure enough, over the last 2 years, his TSH has risen is consistently suppressed. Thyroglobulin was about 3 and has gradually gone up over the last couple of years. These thyroglobulins go up like the waves of the ocean. It's a little bit higher, 3 and then 4 and then 2 and then 3 and then 5, right? I tell patients it's like standing on the beach, trying to figure out whether the tide's going in or the tide's going out. There's peaks and valleys, right? And so there's no question the tide's coming in. We keep chasing with ultrasound. We find an ultrasound now that has a 1.5 centimeter, highly suspicious lymph node. Biopsied, it's papillary thyroid cancer, no question about it. So we've gone through the detectable phase, right? We've watched the thyroglobulin go up. We've chased with ultrasounds until we find something that's actionable. And now what would we recommend at this point? So here she is, 22 years old. Keep watching, do some more cross-sectional imaging of the neck and chest, do radioactive iodine, do some surgery to pluck out the lymph node, or do some surgery to do a little bit more than that. Here's the options. How many people just say continue to watch? Probably not. We need to do a surgery. How many want to do some more additional imaging before you do? Yeah, and absolutely, right? And all the surgeons are like, yes. Because in a situation like this, she needs a surgery, but that could be the tip of the iceberg. You need a CT scan. We would do neck and chest because I want to see the retropharyngeal lymph nodes and somebody that they've done a good clean out on this, right? This has been 2 through 5. They've had the whole neck. And if you're missing something, it's likely to be a retropharyngeal or a high lateral neck behind the clavicle in the upper mediastinum, outside where they operated on. So you don't go in on an ultrasound with this one. So we do CT scan of the neck and chest with contrast. Radioactive iodine therapy worked so well the first time. Let's do it again. So I just told the fellas, it's like if you had pneumonia last year, 6 months ago, and I gave you penicillin, and you came back and you still had pneumonia, you know what I would do? More penicillin. You just need a bigger dose of penicillin, right? Doesn't make any sense, right? So this has lived through the first dose of radioactive iodine, very unlikely to respond to a second one. Remove just the lymph node or remove more? Clearly remove more. In this situation, they're going to find one lymph node, they're going to find more. And so we set that expectation. We're going to find some smaller ones around there, clean out that compartment where it is. Now, if there's truly only one in that area and you have to like crack open the neck to find everything else, no, we can go out and take that one. Tom Fahey did this for me last week. Somebody that had been watching a lymph node for about 10 years. Nothing else was changing and it got cystic and started bothering her. And so we really carefully looked at it. Tom did his own ultrasound. We did CT scans, and we actually just did a berry picking. That was the right thing to do for that particular case. But you can count on one hand the number of times that I've done that over the years. All right, one more, and then we'll stop. So this is a 65-year-old guy. He presents with right hip pain that's messing up his golf game. I get this a lot. This is probably a reflection of my patient base in New York and Manhattan. And he's got a lytic lesion in the right acetabulum and the proximal femur. That, of course, everybody is thinking prostate cancer or myeloma or something crazy like that. They get a biopsy, and then I get a call that says, hey, surprisingly, this shows follicular thyroid cancer. And then, as often happens in orthopedics, We use an ultrasound to find the 5 centimeter lymph, 5 centimeter mass in the thyroid. There is something called physical exam that likely would have found this, but it was way above the waist. Biopsy showed follicular neoplasia. Not a surprise, right? This is a follicular lesion. And so now you've got a 65-year-old guy. He's got big mets in the pelvis and in the femur. And now the question is, how do we sequence stuff? This is clearly actionable, right? There's no question. But the question is, what do we do first? Total thyroidectomy, and then total thyroidectomy and rush to radioactive iodine, molecular testing, systemic therapy with one of the TKIs, evaluation lytic gland, or phone a friend. Who says number one? Number one, first thing you do is total thyroidectomy? No. Number two, total thyroidectomy radioactive iodine? Job. Number three, molecular testing. Yeah, kind of help you, but that, yeah, might be good. Systemic therapy right now? Probably not. Probably not. Yeah, we're voting with 5. Fix the lytic bone lesions. Yeah. So the sequence we do in these lytic bone lesions, we fix the lytic bone lesion first. It'd be a real shame. One of my patients years and years ago saw exactly this situation. They were getting her ready for a total thyroidectomy in the outside hospital. And fell in the bathroom and fractured her femur because the femur lytic lesion hit right on the bathtub where it was. So when we're faced with the distant metastasis in the bone, in the brain, we deal with those first. So get the orthopedic surgeons involved or neurosurgeons if it's spine or that sort of stuff. Ask, is it stable? Do we need to do something to stable? We don't want a pathologic fracture. Fix those bone things first. Once we get the bone things fixed, then we'll come back with total thyroidectomy or radioactive iodine. Remember, there's no rush to do a total thyroidectomy. There's no rush to do radioactive iodine. So fix the distant metastasis and stuff first. Perfect. So let me stop with that. I'll do there. So what I hope I've shown you is to give you a feel for how we use that risk stratification. If you keep that sort of hanging in the clinic, when you see people, where are you? What are the questions to ask? Detectable versus actionable, understanding that we can find stuff, setting up the right expectations if we're going to do minimalistic observations, and understanding that no matter what you think of the tumor, no matter what you think about the medical system, the patients are going to have a vote, and we'll help you sort of make that decision based on their values and their risk and benefits, trying to always give them at least 2 right answers. I tell people, if I think you're doing something wrong, I'm going to tell you that you can still choose to do something wrong, adult, but you're going to know, and my note's going to say, I'm not recommending that, but if you want to do that, I'll follow that with you. But really trying to get 2 right answers so they can risk stratify. Thanks very much. Got a few minutes for questions, comments. We'll finish right at 5 o'clock and be done and get you guys out of here. Yes. Thank you. Yeah, that's great. So this would be in the discussion. The question is, if you're thinking about somebody that'd be good for a lobectomy, and you're trying to figure out, are you a good candidate for minimalistic management? What if they have a family history of thyroid cancer? So papillary family history of thyroid cancer. If they have only 1 or 2 other family members, I don't let that influence me. I tell them 1 or 2 people in your family is like your neighbor having thyroid cancer. That's not 1 out of 10 people in the United States have thyroid cancer. So 1 or 2. That being said, I've got 3 or 4% of my patients that have multiple generations. I took care of granddad, I took care of dad, now I'm doing the grandkids. 5 or 6 people in each generation have papillary cancer. And you would think they would all choose total thyroidectomy. By the second and third generation, they don't, because they know we're finding these so small. Many of them actually do active surveillance for a long time. And when they do surgery, they choose lobectomy. Now, some of them just will say 1 and done and be done. So if they do have 3 or 4 members, we do put that in the mix that we talk about. So it's not a definite thing for me. Partly because I know if I'm wrong, it's no big deal. No big deal to me. I mean, we can figure it out, need another surgery at some point in the future. So as an independent factor, I don't think they behave more aggressively. So I'm open to do it if they want to. They generally don't ask me about that. They have a strong opinion about that for individual people. Yeah, yeah. So the question is, how do we use the molecular testing? There's no question that molecular testing has now become mainstream. There's a couple areas where it definitely works. Indeterminate permanent thyroid nodules, right? These Bethesda 3 nodules that we can't figure out. Molecular testing, there's 4 or 5 different commercial ones that help you risk stratify, right? So I find those helpful, unless I already know the patient's going to surgery. If the patient already needs a surgery, don't spend $3,000. But if it's somebody that would be okay for a minimalistic management, then I think that'd be good. Except for that, the only other place we use the molecular testing is in the distant metastasis setting. And that you can use Foundation, you can use Guardant. Most universities have their own internal program that's a 3 or 4 or 700 gene panel where you're looking for the molecular targets. So in folks that have distant metastasis that are not responding to radioactive iodine, in people that have gross disease that are borderline resectable, knowing if they're a BRAF or a RET fusion or an NTRK, because we have targets for those, ALK fusions we do. So it's only in those really aggressive cases that we do it. Right now, the molecular testing doesn't beat standard anatomical path staging. It doesn't beat preoperative stuff. It adds to it. So if somebody's intermediate risk, we talked about a case this morning that was intermediate risk, had not a great response to therapy, developed distant metastasis, and it turned out it was BRAF plus TERT. No surprise. That's what happens in that tumor. Wouldn't have changed anything he did. You already knew from the TGs that it was doing it. So we don't use it to guide our surgery. We don't use it to guide our follow-up right now. There are probably some instances where we would eventually incorporate that in. So I really see that we'll be laying over the molecular testing over top of the anatomic and clinical staging to kind of further risk stratify. You can certainly use it in the distant metastasis setting, the ones that have BRAF plus TERT or RAS plus TERT or P53, those things, they tend to behave more aggressively. They're particularly actionable if they have a targetable mutation. So that's the setting that we use them in. Yeah, extensive local regional, but usually not lymph node mets. Gross invasion into the windpipe, gross invasion into the, big surgeries that are being having to take out where honestly, those guys are going to have distant mets in a few years anyway. So it's that really ATA high risk group, I guess is what I would say, or older patients that are probably AJCC 3 or 4. And that's probably what, 10% of our patients or 5%, even in an academic center. Yeah. So the question is, do we use the molecular testing in patients with other malignancies? We definitely do, but that's germline testing. So we've got a really active group that's germline testing. In New York, there's a lot of rules about privacy and consent, so we actually do it through genetic counselors. But if anybody has more than 2 or 3 cancers, or breast cancer plus thyroid, or breast plus colon plus thyroid, all of those we just send to genetic counseling and have them have that discussion with them. So yeah, in that group, I didn't used to do such a great job tracking all the other cancers in the families. That's changed a lot the last 10 years. And I've been surprised how many Cowdens I found, how many Lynch syndromes that I found. They're out there. And when I found them in retrospect, I'm like, oh crap, I should have known about that because of this big family history. Absolutely. Okay.